All right, everyone, let's dive into a classic opportunist that every microbiologist should know inside and out. The gram-negative bacillus Eikenella corrodens. It's a totally normal part of our oral flora, just hanging out. But you give it an opening, and it can become a really formidable pathogen. So let's break down exactly why that is.
So here's our game plan. We're going to take a full journey from the bench to the bedside. We'll start with the basics of the organism, then we'll move into how we actually identify it, connect that to the diseases it causes, wrestle with some of the treatment challenges, and then wrap up with how to prevent it.
First up, let's talk about the opportunist itself. We're calling Eikenella corrodens the indolent aggressor. And trust me, by the end of this section, you'll see just how perfectly that name fits.
So what are we really dealing with here? Eikenella corrodens is a facultative anaerobe that, for the most part, lives completely harmlessly in our mouths. But the key thing to understand is its dual nature. It's a quiet commensal, right up until a barrier gets broken. Think trauma, a human bite, or even just poor dental hygiene. That's the opportunity it's waiting for, to invade and cause some really serious, deep-seated infections.
Oh, and just a quick note before we go any further. All the information we're covering in this explainer is a synthesis from a Gemini deep search. If you want to dig into the primary literature, you can find a complete list of all the sources and citations in the notebook document that goes along with this.
Okay, let's head over to the lab bench. This next section is all about identification, and as you're about to see, Eikenella corrodens can be a pretty unique and interesting diagnostic puzzle to solve.
Here it is, the organism's biochemical fingerprint. It's a classic gram-negative rod, and it won't grow on McConkey agar, so that's your first clue. But the key differentiators you really want to look for are oxidase-positive and catalase-negative. That combo is a big signpost. Positive orthonicine and nitrate reduction are also super helpful clues. And finally, it's asaturalytic. It doesn't ferment carbohydrates, which is really useful for telling it apart from some of the other members of the HACEK group.
Now, on the culture plate, Eikenella corrodens is, well, famously fussy. It's a capnophile, so it needs that CO2. It grows so slowly, and its tiny pinpoint colonies can get completely swamped in a mixed culture. But, and this is a big but, there's a really powerful clue for any experienced microbiologist: a faint but very distinct smell of bleach. Seriously, if you smell that coming off a plate, this organism should jump to the top of your list.
And here we have a classic diagnostic trap. The name corrodens literally comes from the bacterium's ability to corrode or pit the agar. But here's the thing, it only happens about half the time. The biggest takeaway here is that you absolutely cannot rely on the absence of pitting to rule out Eikenella corrodens.
Okay, this is so important from a clinical standpoint. Let's talk about the predictable intrinsic resistance profile of Eikenella corrodens. It's just naturally resistant to macrolides, clindamycin, and metronidazole. Now, since clindamycin is so often used empirically for oral flora infections, this creates a major resistance trap that can lead directly to treatment failure if you're not careful.
Thankfully, modern diagnostics have really changed the game for us. MALDI-TOF can give us a definitive ID in just minutes from a single colony, which completely bypasses the delays from its slow growth. And 16S rRNA PCR, well, it's just invaluable, especially in those culture-negative cases where a patient might already gotten a round of antibiotics.
Okay, so we've nailed the ID in the lab. Great. Now let's connect this back to the patient. Why does it all matter? This section is all about the clinical syndromes that this bug can cause. This right here is the absolute textbook case for Eikenella corrodens, the human bite wound. We're especially talking about the clenched fist injury, the fight bite. Just picture it. When a fist hits teeth, all that oral bacteria gets injected, like with a needle, directly into the deep, poorly vascularized space of the tendon sheath. It is the perfect storm for a really, really severe infection.
It's also, of course, a key member of the famous HACEK group, which are known for causing that tricky, subacute, often culture-negative endocarditis. A really critical feature of Eikenella corrodens endocarditis is that it tends to form large vegetations on the heart valves, which leads to a super high rate of embolization, and that means the risk of devastating complications, like a stroke, is significant. And its clinical reach is pretty broad. It's often implicated in head and neck infections that obviously stem from its home base in the mouth, things like aspiration pneumonia, deep abscesses, and even the very specific needle lickers osteomyelitis, which you see in intravenous drug users who use saliva on their needles.
So, all of this naturally leads us to treatment. And this is where the laboratory's role in guiding therapy is not just helpful, it's absolutely paramount.
So, if we take a look at the Dutch swab guidelines, the recommendations are really direct and practical. For a human bite wound, first choice is amoxicillin clavulanate for 5 days. Simple. For the much more serious HACEK endocarditis, you're looking at a long course of IV ceftriaxone, usually for about 4 to 6 weeks.
And what's interesting is you see a really strong international consensus on this. The IDSA and AHA guidelines over in the US pretty much mirror the Dutch recommendations. Amoxicillin clavulanate is the go-to oral agent for bites, and ceftriaxone is still the cornerstone of therapy for HACEK endocarditis.
Now for our pediatric patients, the same principles apply, but careful weight-based dosing is absolutely critical. The drugs of choice are the same, but the dosages, like amoxicillin clavulanate at 25 to 45 milligrams per kilogram per day, have to be calculated precisely.
Okay, this brings us to a really critical question for every clinical microbiology lab out there. We know which drugs generally work, but how should we actually test and report susceptibility when there are no official clinical breakpoints to guide us? And the problem is stated as plainly as possible by EUCAST. They just haven't established clinical breakpoints for Eikenella corrodens. So without validated MIC values to define and isolate as susceptible, intermediate, or resistant, reporting becomes a major challenge for the lab.
But here's the solution. You follow the EUCAST guidance for exactly this situation. It's a nice, clear three-step process. First, do not report agents to which the organism is intrinsically resistant. It just causes confusion. Second, and this is a big one, do not borrow breakpoints from other organisms. And third, the best practice is to simply report the exact MIC you found along with an interpretive comment. This really transforms the lab report from just a result into a clinical consultation.
All right, to wrap things up, let's close the loop. Let's talk about how we can prevent these infections from even happening in the first place. Unsurprisingly, prevention starts right where the bug lives, in the mouth. Good oral hygiene is the absolute cornerstone. Beyond that, it's about educating our at-risk patients, making sure we provide prompt and thorough wound care for bites, and of course, sticking to standard precautions in all healthcare settings. And that is our bench-to-bedside review of Eikenella corrodens. I hope you found this useful. If you did, please consider subscribing for more explainers like this one. We genuinely want to hear from our audience, so please leave your own insights, your experiences, any tough cases you've had in the comments below. We'd love to hear from you.
Thanks for watching.